Hi everyone, and very good evening to all of you. This is a doubt solving session, and I'm available live to you. For any of your queries, you may please put on the chat box, and I'll take your doubts as they come forward. Okay. So, because this is a doubt solving session, there's nothing that I will teach you. You're more than free to ask your own doubts, and let's discuss from there forward. Okay. Recently, the exams, the NEET exam and the NICT are just over. If you find a bit difficulty in understanding some topic based on that, or if some second year, third year, or any foundation student have also joined, please let me know and let me know your actual queries, and let's try to solve it in the best possible manner. Basically, from my side, what I can guide you is if you're reading Gurukul videos, if you're watching to Gurukul videos, ensure that you know that in which year you are, and you must know about the time frame that you can give for every individual topic. That means don't read it blindly. Most important topics from pathology always have been and will be like a hemat. So always start from hemat. Okay, try to read the leukemia lymphomas first. Go to RBC anemia. A lot of questions being asked on RBC anemia now, not nowadays. And then also try to read the bleeding and coagulation topic. Bleeding and coagulation topic from Gurukul, do watch the hemodynamics topic also, because a part of that video also will be seen in the hemodynamics also. After you're done with this hemat video, I will suggest you to then move forward and start general pathology. Now, again, this is a very important thing that you should understand in which year you are. I'm telling this again and again because many students fail to realize in which year they are and ultimately end up reading so much that they are not actually reading what they sure would want. So, what should you do is try to basically watch the videos uh, as to looking into that whether you are a prof student, a second prof student, or you are passed from a prof student. So if you are just now moving to general pathology, then my basic idea is to start from cell injury topic and then move to inflammation, repair and regeneration, and finally move to immune system. After this, try to cover genetics and the neoplasia. Usually, there are few other topics more important for second year, but I'll say for those who are, for those who are actually past second year, for those topics are not very important. I think this is what you must cover. Finally, when you move to systemic pathology, in systemic always start with vessels and heart. I think that is a better way to start there, vessels and heart. And further on, after you have finished vessels and heart, then you can move into anywhere. I would suggest you to move in the way that I have taught you. Try to cover lungs there. GIT is a small topic from pathology point of view, but do read that GIT. And after covering GIT, I think that you will have enough amount of time to cover a liver, kidney, and the CNS tumors only. In CNS, only read the CNS tumors. Don't read anything else. Okay. From this, a few topics of endocrine are very important. For example, the tumors of, especially the thyroid tumors and adrenal tumors like the pheochromocytoma. Those also are very important. Even though you will find a lot of subtopics in systemic pathology, but my idea always is to give those which is very important to you. So I would suggest you that try to read the other topics from the respective subjects. For example, for the bone, try to read it from orthopedics only. But if you're in second year, then watch this video. That is very important for you. But for the bone, you can actually try to cover it from that portion only. Finally, when you are trying to read, suppose dermatopathology, again, I would ask you to first go and read it via the dermatology, that is skin. And if you don't understand any pathological aspect of skin, then I would ask you to come back and go through my videos of dermatopathology. Same also goes for neurons, the skeletal muscles, which has to be read from medicine. But if you don't understand a topic, you can again come back and read the pathological aspect of the same again. Um, Finally, there are few topics at the last which you will find very difficult to understand. But it is very important to understand that unless you don't know in which year you are, you'll actually get lost into those videos. Now, this goes out not only for Gurukul videos, but for any platform that you are in. First, you must understand that what is the limitations, how much time are you devoting, and individual topic will take how much time. Now, that depends. For example, if you have read Hemat from me, okay, anywhere in your second year, third year, fourth year days, and now you're revising it from Gurukul, then you will take just a 4 to 5 hours, right? But suppose you are reading Hemat for the first time, then obviously you will take more amount of time. So try to distribute your entire day looking into what you need rather than asking others that how much time it will take for you to revise hemat, right? So similarly, that also goes from such pathology. Suppose you start trying to read kidney chapter and you ever have watched any video of kidney, the time that you will take is less, right? So don't compare yourself to a second year student or third year student. Everyone has a different need, and the more earlier you identify your your points, it will really become easy for you to move ahead. What happens many a times is students feel it very uncomfortable reading so much and end up confusing themselves. No one else is getting confused, only you are getting confused. So the gist of what I'm saying is, try to understand how much time you have, number one, what is your resources, and thirdly, how much time you will take to cover that resources. Okay. Once you understand that, it becomes very easy for you to move forward. About pathology, I can say that you can completely trust on my videos. Completely. There's nothing you must do uh, apart from this. Nothing. Literally nothing. You can completely trust on my videos of Gurukul if you're watching Gurukul videos, or suppose you're watching face-to-face lectures. So they are really, really more than sufficient. But very importantly, try to solve MCQs to just, ensure that you don't forget stuffs. Many times what happens, students don't revise the notes and they try to add a lot of things in the notes. Ultimately, they get confused what to read and how to revise it. This has happened very much in the previous NEET also, and including this year NEET also. Students have realized that the less they read, the more concentrated matter they read, they try to revise it more and more. It becomes very easy for everyone to revise from there further. Okay. So yes, this is a live session. So I would invite any of you to ask your doubts related to pathology. For example, one of them I've got from Divya Rani asking such cell aging topics. I'll talk about a cell aging topic right now itself. Okay. But for anyone else who wants to know from me any other topic, academic only, please let me know in comment box below. We have a good amount of time and I'll try to finish it and discuss it for you as well. Okay. So since you have asked me about this topic, so the first topic that I'm taking is a cell aging topic. Basically, what is aging? Aging is something in which a cell gets old. So how does a cell gets old? A cell getting old simply means that cell is not able to divide any further. Okay, cell is not able to divide any further is what the meaning of the word aging is. अब देखो, suppose I say what are the factors causing aging. What the most important factor which is causing cell aging is usually the most important factor causing cell aging is usually the free radical injury. Okay, free radical injury. Now remember, we are talking about the cell aging. Right now, we're not talking about the tissue aging or a skin aging. But here's the skin ages because of the collagen cross-linking, and that is why the skin ages. Right now, I'm discussing about the cell aging. So keep that thing in mind. Okay. Acha. So a free radical injury is one of the factors. It can occur because of the DNA mutations. It can occur because of protein misfolding, and a very unique thing called as a defective nutrient sensing. Okay, now what is this defective nutrient sensing? It refers to when more amount of nutrients enters a cell and causes it to divide a lot of time. For example, suppose I draw a cell like this. There's a cell, okay, and in the cell there's a nucleus. So in the nucleus you'll find the DNA, right? There's a DNA here. Okay. Now the question is, what gives a signal for the cell to divide? So the answer to this question is, whenever this glucose enters a cell, it activates this IGF-1 protein, and IGF-1 signals for replication R. It acts via this mTOR pathway. This is the mTOR pathway via which the signaling via which is entirely acts here. Now what happens whenever the glucose enters a cell? When a glucose enters a cell, this will cause DNA replication. So it was proposed that now, because we know that what is happening here is, suppose there's a there is a chromosome. So at the ends of the chromosome there are repeat sequences of 80. Now, these repeat sequence of 80 are called as telomerase. Telomerase. The theory says that whenever a cell divides, this telomerase or not telomerase, sorry, telomere, very sorry, telomere. Okay. The theory says whenever the cell divides, the telomere length after replication, it keeps on shortening like this. Okay. It keeps on shortening, and finally, after multiple replication is lost. For a somatic cell, this replication number is around 60 to 80 times, after which this cell also fails to divide any further. So now we have understood that whenever glucose enters cell, the cell will divide, replicate, and finally it will fail to divide any further. So once the telomere is lost, what happens? The cell does not replicate any further. Because now a cell does not replicate any further, so what happens at this point of time? We can call this point as a cellular senescence. So guys, what is senescence? Senescence is a state of a cell beyond which it fails to replicate. Okay, it's a type of cell beyond which it fails to replicate. So now it was proven that how can a cell delay the aging process? So the delay the aging process is obviously done by number one, and the only way is calorie restriction. Okay, calorie restriction. Because if the calorie is restricted, the cell will not get a glucose, it won't get a IGF-1, it won't signal for replication, and the telomere will not shorten. So one of the best way to restrict the glucose is a calorie restriction. Second way is to activate a protein called as sirtuins. Okay. Now what is sirtuin? Sirtuin is a protein in a cell. It is coded by a gene called as SIRT6. Unique activity of sirtuin is that it will decrease the glucose requirement. One very important factor is decreasing glucose requirement, one way. A second way of certain action is to cause increasing repair of a cell, and because of more repair, the apoptosis decreases. And the fourth and very important action of sirtuin, I should say, is that it activates an enzyme called as telomerase. Okay, it activates an enzyme called as telomerase. So because it activates the enzyme telomerase, the telomerase does not cleave telomere, and as if it leaves cleave telomere, it's not like this. Telomerase, it will maintain, okay, it maintains the telomere length. Okay, the telomerase, it maintains the telomere length. It maintains telomere length. That is how the entire action of telomerase is. Now this sirtuin is often activated by intake of red wine. Yeah, you heard it correct. Red wine. So two ways of delaying aging. One would be the calorie restriction, and one is red wine. Red wine is not a very proven way. The proven way is the first one, which is restriction of the calorie. So calorie restriction is the best way, and I'll say the only possible way to cause a delay of cellular aging. So I think this is all about the cellular aging. Two questions were asked this year in NEET PG about this cell aging topic. One was the action of telomerase. Telomerase maintains or increases telomere length, and therefore it delays aging process. And the only proven way of delaying aging is the restriction of the calorie, was one other question, and the exact option was calorie restriction by 30% was the exact question in this year's NEET PG exam. Okay, so it is, I think it was quite solved. Dr. Divya Rani, I think I have solved your queries. If yes, do let me know. Okay, and yes, I want you to just put a like to this video as well. Okay, it will really motivate all of us putting a like to this video. Okay. Harsh Parmar, sir, please conduct a session for counseling. Harsh, this session is being conducted actually. If you're from Delhi, the counseling session is going to be held on 14th of this month in Delhi Center at and you will be, or I think you might have seen that poster in the eGurukul Facebook group as well. So if you're from Delhi, you're more than welcome to attend it. And if you're not from Delhi, then we'll always do an online session for you as well. So any updates in pathology to be covered in NEET 23? Yes, Sheikh, try to cover about the recent classification, the brain tumors, CNS tumors recent classification, and tried also to look into the various genes introduced in the hematology, especially in the leukemias and lymphomas. Okay. Um, Nikunj Talwania asking, sir, hello, sir. First vascular event of acute inflammation is vasoconstriction dilation. Nikunj, what has happened is in the recent edition of Robbins, you will find that they have changed their first event of transient vasoconstriction. They have removed it and instead of writing vasodilation. It's better you move into that only. So for acute inflammation, my suggestion to you is to go for vasodilation. However, the question is about the endothelial injury occurring in the hemodynamics topic, that is thrombosis. At that point of time, you can surely answer transient vasoconstriction. But for answering your question, because you're asking about the question on acute inflammation, then the answer is vasodilation only. Okay. Gosne Mohiddin asking, good evening, sir. In iron deficiency anemia, transferrin increases. Yes. Then why transferrin saturation decreases? What is the difference between them? Well, that's a very good question, Gos. So what I'll do is I'll try to talk about this in a image based manner. I'll just open one of the images. Just give me a minute, okay? Okay. So looking at your query, you have asked me about the iron deficiency anemia, and you need to know, sir, why in iron deficiency anemia, even though the transferrin saturation decreases, the transferrin level increases. Okay, so to answer your query, let's have a small revision of iron deficiency anemia also. Dekho, in GIT, we have the ferric form, and ferric form is reduced to ferrous form. A ferrous form can be absorbed by this molecule called as DMT1. I think you know about this. Now, Dekho, what happens is, one second. Yeah, they go. So what happens is, if you look at this image, basically what is happening is this: after getting absorbed from here, a small portion is being stored in the form of mucosa ferritin, while majority is taken from the basal surface by this molecule called as ferroportin. Okay. Once this ferroportin comes out of the GIT, it is taken into the vessels by transferrin, right? So this Fe2 plus is again oxidized to Fe3 plus by this unique protein called as hepestin. So after getting oxidized, the Fe3 plus is captured by transferrin, which brings it to the bone marrow tissue storehouse, and now they can be given to the erythroblast. So now your question is, sir, why in iron deficiency anemia the transferrin saturation decreases but transferrin level increases? Look, basically what happens in iron deficiency anemia is there is decreased hepcidin value. Why? Because liver wants to absorb more iron. To absorb more iron, liver has to increase what? Ferroportin. And therefore, it will decrease hepcidin. The moment it decreases hepcidin, it will increase ferroportin. Now remember, once the ferroportin is increasing, so more iron is coming out from here. Once more iron is coming out from here, who will absorb it? Transferrin. So liver also increases this transferrin values. It increases. But the point to understand is this compensation occurs later on. First of all, what happens is because less iron going inside, less iron getting absorbed initially, the serum iron is decreased and transferrin saturation also decreases initially. Then the liver understands, oh my god, the iron is less. Let's try to decrease hepcidin, increase ferroportin, at the same time also tries to increase transferrin. But that's a later response. Before that, the serum iron and transferrin saturation is already decreased. Once the transferrin level increases, then is when the TIBC starts increasing. But that is again a late response. Overall, what you see is because still the patient has less amount of iron. Please understand, it will take the iron storehouse to replete at least few weeks, right? So till that time, the iron absorption is still not to the mark that it must happen. And because of low iron absorption from here, the transferrin saturation decreases. But because of transferrin level increasing, the TIBC increases. Okay, I think I was able to make this clear to you, Dr. Gos Mohiddin. Is it okay? Okay. So, yes, Bayan Gari Shashank asking me, sir, please talk about. One second. Oh, sorry, sorry, sorry. There was a sorry, sorry, sorry. Yeah, yeah, yeah. Okay. I think now the voice will come. I'm very sorry and thank you. So I just repeat what I said. I'm just repeating what I said. Hypertrophy and hyperplasia. Okay. So what happens is there is increase in cell size and increase in cell number here. Okay. अब देखो, there is increased workload and increase in workload, which is a cause of both hypertrophy and plasia. We have to basically know the causes of hypertrophy and hyperplasia. In hypertrophy, in hypertrophy, what happens? There's physiological hypertrophy and there is pathological hypertrophy. Basically, physiological hypertrophy is in those tissues which have or which cannot divide. Like for example, the skeletal muscles and cardiac muscles, skeletal muscles and the cardiac muscles. Okay. However, uterus and breast as such, they have limited capacity to divide. So this can partially divide and partially not. So these two examples come in both hypertrophy and hyperplasia. But remember one thing, guys, that the moment the question is breast during lactation, in this case, in lactation, answer only hypertrophy, don't answer hyperplasia. Okay. Pathological causes of hypertrophy, pathological causes of hypertrophy are cardiac hypertrophy in hypertension, cardiac hypertrophy in hypertension. Okay. Whereas pathological examples of hyperplasia are estrogen causing endometrial hyperplasia and androgen causing benign prostatic hyperplasia. The third example is metaplasia in which the stem cell will change from one type of mature cell to other type of mature cell. And what is the cause? The cause is stem cell reprogramming. Metaplasia are of two types. One is epithelial and one is connective tissue metaplasia. The only example of connective tissue metaplasia is myositis ossificans. Epithelial metaplasia, it can be squamous or can be columnar. A squamous metaplasia in lungs is seen in smoker, vitamin A deficiency, and chronic obstructive pulmonary disease, whereas endocervix may it is seen in infection, especially by the human papilloma virus. Okay, bile and pancreatic duct, they can be seen in stones, and bladder in stones and schistosomiasis. Barrett esophagus, it is seen in GERD, and this topic is very, very important, and so let's discuss this separately also. So what is happening here is, this is esophagus and this part is stomach. Esophagus is lined by squamous epithelium, while the stomach is lined by columnar epithelium. The stomach has a layer of mucin here, which prevents the damage to this epithelium here. The mucin, it comes from the mucin secreting cells of the stomach. But the moment this any acid refluxing back into lower part of the esophagus, this part gets damaged, and therefore it will change its normal squamous epithelium to columnar epithelium. Often this type of epithelium, they have in between goblet cells, because normally we see goblet cells in the large intestine, and hence we can call this intestinal type of metaplasia. We can call this intestinal type of metaplasia. Remember one thing, goblet cell is a hallmark finding of metaplasia. Well, Barrett can go to dysplasia, and which can then progress to adenocarcinoma. The fourth one is atrophy, which can be physiological atrophy like a notochord atrophy during the embryogenesis, and pathological atrophy can be nutritional, ischemic, pressure, saline atrophy in the brain, and can also be seen in denervation. Okay, the examples of physiological and pathological atrophy here. Okay, this is all about the cellular adaptation. If you have any doubts, more than free to ask me, guys. Question was asked to me by Dr. Bayangari Shashank, and I think that I have made it very clear to you. Okay. Yes, guys, I think if you are getting benefited, just put a like to this video. It really motivates the entire team of DBMCI. Hello, sir. Pathology important topics for NEET. Right now, Bunny, every topic in pathology is important for you. Every topic. So there's no important, less important right now, because your preparation is starting for you. Every topic in pathology is important. Only in the last few months we go after the important topics. Okay, right now, because you're preparing for NEET 2023, my suggestion to you is read every topic that is taught. And what to read? If you watch the beginning of today's video, in this video only, the beginning 5 minutes, I've told you how to approach pathology from Gurukul videos if you are watching those videos. Okay. Dr. Butt asking, sir, how to study pathology? How to study pathology? Dr. Butt, it is very important to understand that if you're actually appearing for the NEET 23, you have other 18 subjects also to solve. Okay, so restrict your time for pathology, I'll say, to at least 8 days if you have never read it. And if you read it, then you can cover it in 6 to 7 days. Okay. Now try to approach pathology first by covering hemat, then to general pathology, and then to covering systemic pathology. Any topic which you know is very much overlapping, for example, entire orthopedics bone, the dermatology is skin, the neurons by medicine, endocrine by medicine, don't read it mainly from pathology, read it from respective subjects only. And when you have to know something about the histopathology of the specimen, then come back and look into those videos which are made for you in the Gurukul videos. Okay. Yes, any other doubt? Dr. VP asking, sir, how is pathology for a student who is not studious? Can we do well? Are you asking for the residency, PG degree, PG residency? Please make your question clear. Okay. I'll just get some water. Okay. Okay. So your question is, yes, for residency. So I believe that for residency, yes, you must be a bit studious to actually go to any paraclinical subjects, because paraclinical subjects are more about reading stuffs. Yes, it's very important to understand that practical view also. So you have to watch the slides, read the slides, but the entire staging you must be, aware of, and you must read the stagings on a daily basis. So yes, I will say that for pathology, you must be a bit studious. Um, well, anything is manageable. So I believe that if you're doing it from good college, for example, if you're doing it from AIMS or any central institutes, they will push you to read to the maximum. Okay. Sir, can you please tell us about the L3 in ALL and Burkitt lymphoma, and how CML can transform to AML in chronic stage? It's not like that CML transforms like this only, but because of one more mutation, sometimes the CML cell starts not maturing, because the CML cells don't mature, then it converts to a CML in blastocysts, which is often almost equivalent to acute leukemia. Okay. Coming to the second question that you're asking, sir, can you please talk about ALL L3? So what happens in ALL L3 is, देखो, ALL L3 is a acute lymphoblastic leukemia in which the tumor cells have cytoplasmic vacuoles. So because they have cytoplasmic vacuoles inside them, they actually look like the Burkitt lymphoma cells. Now, initially it was thought that actually Burkitt lymphoma cells, they are different from ALL-L3. But because of the recent immunophenotyping available, it was proven that it is not different. Actually, ALL-L3 is not ALL, it's a misnomer. Actually, what was happening was that any patient who was suffering from Burkitt lymphoma, in Burkitt lymphoma, the bone marrow involvement is also very common. So because bone marrow involvement is common, the morphological aspect of bone marrow is the same cell with cytoplasmic vacuoles, and therefore ALL-L3 term is not used nowadays. We only use the Burkitt lymphoma cells, which actually have, I'll say, infiltrated the bone marrow, giving that typical morphology with a cell having cytoplasmic vacuolations. Okay. Sir, please talk about Ashif Shaban PT asking. Sir, can you please talk about little about myositis ossificans? So, देखो, myositis ossificans is very simple. It is something called as dystrophic calcification. So, if there is a muscle and the muscle has repeated trauma, so what happens, that area of muscle will have some calcium deposition. The trauma will destroy the muscle first of all, and on the destroyed piece of muscle, the calcium will keep on depositing. Now, because it's a type of dystrophic calcification, the calcium level in the body is not increased. It's only calcification in the muscles with normal serum calcium level in a degenerated muscle. It is called as myositis ossificans. Okay, it is called as myositis ossificans. Is it clear? For a student who wants to keep the options of moving abroad open, is MD pathology a good option? Yeah, why not? Surely, yes. But for that, if you want to go out, it's not like a radiology in which you will be absorbed without writing an exam. For every other branch apart from radiology, you have to write an exam for that country. For example, you have to apply for USMLE, you're going to US, or PLABS for the UK. Elsewise, you won't be able to work there. Okay. Acha. So a few words for malakoplakia. Okay, I'll talk about malakoplakia now. Malakoplakia. Okay. This is malakoplakia, in which you can see there is a bladder, and inside the bladder you can see this lot number of white plaque-like lesions. This is white plaque-like lesion. These all white plaque-like lesions is often seen in what is called as malakoplakia. So what happens in malakoplakia is, it's a chronic inflammatory lesion of the bladder. Chronic inflammatory lesion of the bladder, because of which what happens, that this is due to an infection. Often the infection you see in malakoplakia, you often see in malakoplakia is of a Escherichia coli. Okay, it is often of the Escherichia coli. Remember this. Okay. Secondly, What happens is the moment there is an infection, the macrophage tissue of this bladder will engulf the E. coli and gradually we also have a calcium deposition inside it. So microscopically, they show this type of finding. This all black deposition is inside this big macrophage, and inside this macrophage, this black one is a calcium deposition inside the macrophage. This small deposit here is called as a Michaelis Guttman body. This all black deposition is a calcium deposition in the macrophage. This is a macrophage, and inside this calcium deposition, it is called as Michaelis Guttman body. Okay, Michaelis Guttman body. It is what is called as malakoplakia. It is what is called as malakoplakia. Okay. Next question, sir. Means local calcification without blood calcium level increasing. Yes, in a way, yes. That's very true. Very true. Okay. Sir, please talk about some words for retinal angiomatosis. What is angiomatosis? Angiomatosis is something which is called as a diffuse, it can be called as a diffuse vascular lesion which looks like hemangioma. Listen to me again. Angiomatosis is a diffuse vessel lesion which looks like a hemangioma. Okay, actually there's multiple tissues and there are vessels of small and large diameter. Vessel of small and large diameter. But look at the name. Angiomatosis also has a lot of adipose tissue around it. So basically, if you find there is a vessel, there is multiple vessel proliferation, and along with that you see a lot number of adipocytes, it is called as angiomatosis. Okay, it is called as angiomatosis. When talk about the, you are asking about the retinal angiomatosis. It is seen in a von Hippel-Lindau disease. I hope you remember the mnemonic I always give in my class for von Hippel-Lindau. Hippel-Lindau, Hippel has a mnemonic also of Hippel. H is hemangioblastoma, I is increased risk of clear cell carcinoma, R is HIP, P is pheochromocytoma, next P is port wine stain, then there is eye lesion, which you are asking me is retinal angiomatosis, and there is lung cyst. Okay, it is seen in the von Hippel-Lindau syndrome, which is on chromosome number 3 long arm Q. Okay. Dr. Ashutosh Sharma asking, sir, please talk about pathological finding of different glomerular disease. So Ashutosh, a lot number of glomerular diseases are there. I can basically sum it up and tell you the basic finding. देखो, I'll just answer a funny question here. Sir, your note definition is not accepted by professor. They want to remember Robbins only. I think you must show your Robbins to your professor, and my notes definition is exactly same as what is written in Robbins. Okay. PSN, in PSN you see three types of finding. In EM you see the hump formation, this hump, it's called as subepithelial humps. In the fluorescent microscopy, what you see is what is called as a starry sky appearance. In the light microscopy, it shows maximum endo and exo capillary proliferation. In RPGN, we see crescents in the microscopy and flea-brain kidney in the gross morphology. In EM, we see the rupture of GBM. In fluorescent microscopy, you get a type 1 RPGM showing linear deposits and type 2 RPGM showing you granular deposits. In IgA nephropathy, we see mesangial deposition, and those deposition usually is of IgA only. Okay. Then in the membranous glomerulonephritis, you see diffuse GBM thickening. As you see in this image. In the electron microscopy, you can see the flattening of the podocytes, and along with that you can see the subepithelial dense deposition along with that. Okay, this flattening of the podocytes, which is called as podocytopathy, and along with that you see this dense subepithelial deposits in the MGN. Coming to the minimal change disease, you see diffuse effacement of the podocytes. As you see in this image, it is also called as podocytopathy, but this is seen without any change on the light microscopy. In the FSGS, you see less than 50% of the glomerulus being involved, so less than 50, and only involving a part of the glomeruli. So this is called as FSGS, focal segmental glomerulosclerosis. Okay, it is called as FSGS. Now coming back to what is seen in MPGN. In MPGN type 1, you see this double contoured GBM. The double contoured GBM is called as tram track appearance or duplication of GBM. Whereas in MPGN type 2, you see what is called as a dense deposit disease. Okay, I hope you liked it. We have just concluded everything about the nephrotic syndrome in just around 2 minutes. Okay. Okay. Bharat Kumar ji, sir, without any mutation, does the RB gene stays in active or inactive form in normal cells? So, Bharat, RB gene has to shunt between active form and inactive form. Okay, RB gene is active form, and when the growth factor comes, it converts to inactive form. Okay, so RB gene shunts between active and inactive form in normal state. However, when it becomes mutated, it permanently changes to the inactive state, in which it cannot stop proliferation, and proliferation continues without the requirement of any growth factor. Can you give a list of all pathognomonic cells and respective conditions? No, that is not possible. It's a very big list, and I'm sure I will miss some. Better you watch every video and try to make your own notes. Okay. Explain in short a Warburg phenomenon, sir. Dekho, what happens in Warburg? I'll just show you an image to understand it better. Dekho. What is Warburg effect? In Warburg effect, look at the first image here. Here the glucose is entering this cell, and in a normal cell, okay, normal cell, glucose enters a cell. Then with the help of oxygen, it makes pyruvic acid, and without oxygen, it makes lactic acid, right? So pyruvic acid, now with the help of Krebs cycle, it goes to electron transport chain and finally makes ATP. This is a normal cell. However, if you compare this normal cell to a tumor cell, in tumor cell, the glucose entry is very high. First difference. Second difference is, even with presence of oxygen, it makes lactic acid. So we all know that if there is no oxygen, every cell makes lactic acid. What is new here is, even in presence of oxygen, it makes lactic acid, and hence the name is called as aerobic glycolysis. The name is called as aerobic glycolysis. It makes lactic acid. Then it goes to mitochondria, and from the mitochondria, it makes nucleotides, amino acids, and lipids. Okay. Synthesis of more tumor cell is the reason there. So basically, what Warburg effect is, a Warburg effect is an altered cell metabolism. That is, to use glucose not to make ATP only, but to make the intermediate products of more tumor cells. For example, nucleotides, amino acids, and lipids. They make intermediate products for more tumor cells, which are nucleotides, amino acids, and lipids. And this helps in synthesis of more and more tumor cells. One of the applied importance of Warburg effect is a PET scanning called as positron emission tomography scanning. Okay. Okay. This is about the Warburg effect. It's about the Warburg effect. Sir, about the interstitial cystitis, it's just an inflammation of bladder, in which there is a chronic inflammation of bladder, in which it can lead to pelvic pain and also the swelling of the bladder tissue also. It is not exactly a pathological condition, it's mostly a clinical condition and can be treated by a long-term antibiotics there. But because it is a chronic inflammation, it often can show you, it can progress to a cancer, and can also progress to a rupture of bladder. Okay. What else? Pata. Okay, there's one more question. Sir, why is there hepatic dysfunction in case of RCC? Actually, it's a para neoplastic syndrome, which by definition itself tells you that there are those signs and symptoms which cannot be explained by anatomical location or the hormones released from the tissue from which these tumors are arising. And therefore, you cannot explain why is there hepatic dysfunction in RCC. And hence, it is called as para neoplastic syndromes. Okay. So don't normal cell also make nucleotides? They might make it, but not from the glucose entry, and that too in the mitochondria. Okay. Malakoplakia, I have just discussed this before this topic. If you go back to this video around 10-15 minutes, you'll find this topic discussion of malakoplakia. Go to that topic, you'll find it better there. Sir, explain briefly about inflammation and healing. Oh my God, you have come, not briefly, you have asked me entire 2 chapters. One is inflammation and one is healing. It's a very long chapter. I don't know how well I just sum up it up here. But what I can do is, I can tell you a very simple way to revise it. I hope that you all have gone through my videos of my own channel. I'll just send that link here, and that will help you. Okay. Just go to my channel, and there you can watch a video of inflammation. If you can just revise this entire inflammation topic in just 2 minutes, I'll just put that link. It'll be easy for you to revise therefore. Okay, just give till that time. You may please ask me other topic as well. Yeah, I'm just sharing that link with you. Okay. Uh, Please subscribe to my channel and just go to this link. It will really you can easily revise it by this link. Okay, because else this entire thing is very long. I can just tell you what to focus on here. Try to focus on basically the cellular events of inflammation and the chronic inflammation, and then try to watch this in revision of repair topic as well as. Okay. What is the classification of NET? Classification of NET means, I think you should just again ask a question. So, what topics from Gurukul app can be skipped from NEET 2023? If you're reading it for the first time, don't skip anything. But as I told you, I've talked about this multiple times in this video. If you watch this video from beginning, you'll get that answer to the question that you're asking me right now. Asif Shaban asking you, sir, can you talk about the dostarlimumab? Okay, now this is a new drug. Yes, dostarlimumab. Surely I can talk about this also. So to answer this question, I have to just show you some, images here. One second, please. One second, please. Okay. Yeah. Okay. So to understand this entire story, you have to understand how does the immune checkpoint inhibitor works. Okay. Therefore, what happens normally in normal state is APC, the APC, it can pick up the tumor cell and via the MHC and can present it to the T cells. Okay. One more activation required here is a B71 and B72 on the APC, activating CD28 on the T cells. Okay, so what happens is a tumor cell knows this entire physiology, and tumor cell makes molecule like CTLA4. The CTLA4 molecule goes and block the B71 and B72, so 28 is not activated. Okay. Apart from this, the tumor cell also upregulates the PDL1, which can bind on the PD1 molecule on T cells. The moment a PDL1 molecule binds on the PD1 molecule on T cells, the T cell is inhibited. So how is the tumor cell escaping the immune response? One of them is production of this CTLA4, another is increasing PDL1 and PD1, which can inhibit a T cell. Now comes the drugs. देखो, if we can make an anti-CTLA4 antibody, or we can make an antibody against PDL1, or we can make an antibody against PD1, basically the T cell is not inhibited. If T cell is not inhibited, the T cell can destroy the T cells. Now multiple of those drugs are introduced therefore. Now see, this is a big list. The anti-PD1 antibody is two drugs, nivolumab and pembrolizumab. A very recent addition to this is what you are asking me, that is dostarlimumab. Okay, dostarlimumab. So you have to check the spelling there. You are asking me. It is DOSTAR, dostarlimumab. Dostarlimab actually, dostarlimab. Okay, so dostarlimab, pembrolizumab and nivolumab, these are the PD1 antibody. Oh, sorry, this last one is PDL1 antibody. This one is PDL1 antibody along with the alazumab. So this dostarlimumab is a PD1. Oh, very sorry. Is actually a PD1 antibody. I was just wrote it correctly initially. This actually is a PD1 antibody. Along with that, the previously approved drug are nivolumab and pembrolizumab. But the point to understand here is, yes, it is a cure of cancer, but only if the tumor cell expresses the PD1 or PDL1 molecule. If the tumor cell is not expressing PD1 or PDL1, there is no use of this drug. Therefore, even though it's a very, very good discovery, no doubt about it, but the limitation will be to those tumor cells which express only PD1 antibody, else it cannot. Okay, else it cannot. Look at these drugs, and the uses are in non-small cell cancer, melanoma, Hodgkin's lymphoma, and also in renal cell carcinoma also. Okay, is it clear? So if you're liking this video, just put a like to this video. It'll really motivate all of us. If you're liking this video, in this kind of academic discussion, then please like this video also. So different CD markers, how to remember this? Very simple. Basically the CD markers is very simple to remember. You have to just look at the list there. Just a small revision. Any cell which is immature will have CD34 positivity. The moment a cell WBC matures, it becomes CD45 positivity. So 3-4 immature, 4-5 mature. Okay. A mallard marker is M for mallard, M for MPO. Okay. Other than that, 13, 33, 117. Don't worry about it. Remember MPO initially. For B, remember 19. The moment you remember 19, you cannot forget others, right? 19, then 20, 21, 22, 23, 24. For T, remember 3. T, remember 3. And if you remember 3, you can't forget others. 1, 2, 3, 4, 5, 7 and 8. Forget about 6. NK में all markers have 6 at last. 6 at last. 16, 56, 96. And mono में or have 4 at last. 4, why 4? Because mono is a 4-letter word, so 4 at the last. 14 and 64. 14 and 64. So easy. All CD markers you can remember in this way. All CD marker you can remember in this way. So please share NEET 23 important topics. I'm telling you, Shaq, it's not the right time to share any important topics. Okay, right now you must read everything, and what you must read from that everything I've told at the beginning of this video. But don't go after high link topics right now at the beginning of a preparation for NEET 23. Had the exam been 2 months ahead, then I would have been the right person to tell you important topics. At this point of time, I won't suggest you to watch only the important topics videos. ठीक है? So please explain classification of amyloid. Amyloid can be classified localized or systemic. Localized has 4 examples: Alzheimer, Melry thyroid carcinoma, it is insulinoma, and isolated atrial amyloidosis. In secondary, it can be systemic, it can be primary or secondary. Secondary includes chronic inflammation, malignancies, and autoimmune disease, and can release AA amyloid. Now, in the systemic, the primary includes two inherited diseases. One of them is familial Mediterranean fever, and one of them is familial cardiac amyloidosis. Others which can be there are dialysis associated and senile amyloid polyneuropathies. Bas, so simple. What is red degeneration? Red degeneration often occurs in a fibroid in which there is a lot of hemorrhage in the fibroid and becomes very painful to a lady. Why does a defect of beta 2 integrin causes delayed separation of umbilical cord? It is because the beta 2 integrin helps in the separation of umbilical cord. So because this integrin is not there, so this umbilical cord does not come out from there. Okay. Sir, can you help me to get MD medicine seat through NICT? I cannot help you, but yes, I can guide you. So if your rank is between around 100 in NICT, then I'm very sure you can get the MD medicine. It can go up to 150, but I don't expect this medicine to go beyond 150 this time at least. How to differentiate nodular lesion in diabetes mellitus and sclerosing lesion in FSGS histopath? A lot of difference. The nodular lesion in diabetic nephropathy will be on one side and a small nodule like, but in a FSGS it won't be a nodule like, it will be a large lesion on entire one side of the kidney. And secondly, usually a Kemmel-Wilson lesion is not a separate lesion altogether, will also have the mesangial proliferation also. It won't be just a single isolated Kemmel-Wilson lesion which you're talking about as nodular glomerulonephritis, but it will have also mesangial proliferation also in diabetic nephropathy. Okay. Should I study subject wise or system wise? I think that you must read subject wise, not system wise. What kind of questions are expected in December FMG exam? Very clinical. All clinical questions you can expect. Don't expect a non-clinical question. So always try to correlate the two subjects together and then move forward when revising stuffs. Initially, read them separately and then correlate it to move ahead. Okay, then correlate it to move ahead. Okay. So I think we were able to discuss a lot of things in this video, and I think that it might be very fruitful to you. Please let me know if I can help you in any other question also. Maybe I can solve it in a better way there. Okay. Do you have any other doubts? I am still available to you. If you can ask me any doubts, you may please. Till the time I just answer a few questions more that have been asked here. CD markers already answered. LAT2 have answered. Red degeneration have answered. Classification of amyloidosis, yes, I've answered this also. Okay, different stains and characteristics, yes. So stain and characteristic, I have already shared this in my Telegram group. If you are a member of the Telegram group, you can download from there also. The long list of the stains and their what it actually stains, but it's a very long list. I don't think it's very important to remember those stains. Actually, don't bother about this a lot. I know that it's very much difficult for a student to understand, ki, sir, how a stain is not important. But usually when you attend my class, I talk about different stains at different areas always. So better you read the stains where they belong rather than just bunging up those long list of stains and which tissue it stains, because it's very difficult to remember so many stains. It really is very difficult. Okay. If you're a student of DBMCI, then the best source of MCQ is to go through the eGurukul subject-wise question bank. That's the best source. Don't go to any other source. If you have Gurukul, go to the subject-wise question bank of pathology. All questions have been made by me, verified by me. So you will get the best question bank of Gurukul pathology. I can vouch on the fact. Solve it and then you realize how good it is. Okay. How many past papers should I solve now? I think you should go up to an 18 at least. Sir, I have decided to follow the pathology book. I have to answer it. Mallory Deng body is seen in a simple mnemonic weight in PHC. Weight in PHC matlab Wilson. A is alcoholic. I is Indian. Childhood cirrhosis. T is alpha-1 antitrypsin deficiency. And PHC is primary biliary cirrhosis. And HC is hepatocellular carcinoma. Last question, guys. In leukemia, can you say which is more common age group? So in ALL, it usually occurs in younger age group, and AML usually occurs in the mid to older age group. ALL and AML. Okay. So I think it was a quite beneficial session to all of us. If you realize this lecture, then please put your comments after this video ends it. After the video finishes, please come back and put your comments box below, because the live chat, I cannot read those live chat after the video finishes. So a small request, if you like this session, then please, after the video ends, please put your comment in the video as well. Okay. Thank you guys. Take care. Good night and God bless you all. Stay healthy and stay happy. Okay. Read in the best possible way. Don't overburden yourself with a lot of stuffs. If you're watching my videos, if you're reading at the stuffs of pathology, do follow my videos. It's really more than sufficient. And do follow my channel also. You'll get a lot of new things actually getting updated. Okay. But for MCQ purpose, just solve one thing, and that is eGurukul question bank of pathology. That's it. Nothing else is required. Okay. Take care. Goodbye and God bless you all. Bye bye.